Hi, I'm Kathleen Digre, and I'm a professor of neurology and ophthalmology at the University of Utah in the Division of Headache and Neuro-Ophthalmology and also in the Department of Neurology. And you're at Headache School tonight. This is a presentation that is being recorded because there are many people who can't attend at this particular time because it's family time, but yet we want to be able to share information. This is a topic that many people have requested, and that's why we're giving it. And the question is, how do I escape medication overuse when nothing else works? And at the end of this presentation, we will stop recording, and then you can ask questions, and we can chat and talk about things that you want to talk about or whatever. So that part won't be recorded. So I'm going to start with a case, a woman, a Sharon. She's a 45-year-old teacher and mom. So she was diagnosed with migraine when she hit puberty, which is a very common time to start having migraine. And she had regular menstrual period related migraines. And sometimes she'd get a migraine in between as well. Then in her early 40s, she had more migraine, not just with her periods, but almost every week. And she was using ibuprofen, which worked for her. And then recently, her primary care had given her sumatriptan. And so she was using that. And over the last year, her headaches just started to steadily worsen, and she started missing her work, calling in sick. She missed home activities. She had 4 severe headaches every week. She took a triptan, and for 5 days a week, she used her ibuprofen. But when she'd take it, it would help somewhat, and then the headache would recur the next day. And so I asked the question, do you have any headache-free days? And she said, no, none. Does that sound like you? She said, nothing is working. What am I going to do? And so that's our goal tonight, is to help Sharon and thereby help other people who have the same problem. So what is going on here? Let's just talk about what's happening here. So we divide migraine into episodic migraine and into chronic migraine. Chronic migraine is more than 15 days a month, and this is just by convention. There's no real science behind what is chronic migraine, but we just arbitrarily have divided episodic 15 days a month or less, chronic more than 15 days. So if you're going to look at Sharon, we're going to diagnose her with episodic migraine or chronic migraine. We're going to diagnose her with chronic migraine because she has a headache more than 15 days a month. She has a headache every single day, and she's taking medications to treat that migraine. Okay. She has 16 sumatriptan days each month, and she takes ibuprofen 20 times in the month. And so she asked me the question, well, is that too many? How many is too many? So now here we do have some information. There are 2 reasons that medications can push us into chronic headache. And we're going to talk about both of them. One is you progress from episodic migraine to chronic migraine, and these medicines can push us into chronic migraine. And the other is medication overuse headache. So we're going to talk about both of these, okay? And if you take an opiate, any of the opiates, more than 8 days in a month, you are at very high risk for going into chronic migraine. If you take a barbiturate, that's like Fiorinol, Fioricet, more than 5 days a month, you're in danger of going into chronic migraine. If you use a triptan more than 10 to 14 days a month, you're in danger of going into chronic migraine. If you use an analgesic with caffeine in it, and by that I mean things like Excedrin, and there are other preparations that are out there as well, 10 days a month, just 10 days a month, you're in danger of going into chronic migraine. Uh, Anti-inflammatory medications like ibuprofen, naproxen may be protective if it's used less than 10 days in a month. And so Sharon is already at a danger point of going into chronic migraine from just the number of medications she's taking. Then, if you are taking uh, medications more than usually 10 days a month, you're in danger of this medication overuse headache. And what this comes from taking almost daily medications for your headache. And everybody says, "Well, I never take it unless I need it." But as you can see, that uh, there's two problems with overusing the medicine. One is pushing yourself into chronic migraine, and the other is giving yourself medication overuse headache. Not everybody who takes too many medications develops either chronic migraine or medication overuse headache, but most people who overuse their acute medications like ergotamines, triptans, opiates, combination analgesics with caffeine, or any combination more than 10 days in a month, they're in danger of getting medication overuse headache. Now, some people say to me, "Well, I'll take a triptan one day, I'll take an ibuprofen another day, and then I'll take my Excedrin another day." Well, that still is a problem because remember, it's any combination more than 10 days a month. Okay. What about Sharon? She's using way too many medications and she's in definite medication overuse headache. All right. Sharon says, "I'm between a rock and a hard place. What am I supposed to do? I have to work. My migraine gets worse, so I take more medication. I take more medication and my migraine gets worse. What am I going to do?" So let's come up with a plan for Sharon to get out of medication overuse headache. Now, the first step is to recognize it. If you recognize when medication overuse headache has occurred, usually in the setting of chronic migraine, when you have headaches, migraine headaches more than 15 days a month, and you're taking too many either nonsteroidals, triptans, or other medications, you do need to work with a provider to find a solution for you. But step one is recognition. Okay. Step two is that there are many ways to get out of this. Okay. And that's one hopeful point I hope you take away from tonight. And there are many ways to stop using these medications. And we're going to talk about more ways to keep yourself doing better. But the first way you can do it is to stop cold turkey. So here's a cold turkey sitting here shivering with icicles coming down off of its little wings. And what that means is you stop all the medications acutely, and then you change the acute medication to something else, plus you add a preventive migraine medication. Okay, that's one way to do it. A second way to do it is to start a preventative and then come off the acute medication as well as you can, plus change that acute treatment. So you've got to kind of stop that medication that's being overused and come up with a different tactic. The third way you can do it is to taper off the acute medication and hope that the overuse headache goes away. And then another way to do it is to start a medication that doesn't cause medication overuse headache. And I'm going to give you these medications that can be taken more frequently that will not give you medication overuse headache. Now, whenever I talk about chronic migraine, medication overuse headache, we've got to talk about prevention, because if we can prevent migraine, we've got a great chance of coming off any acute medication and we can stop overuse headache. And I want to point out the American Migraine Foundation, this little cartoon here. I mean, it's it it it's focused on patients, treatments, understanding foods, triggers, prevention, causes, etc. So migraine is complicated, and join the American Migraine Foundation. That'll be another message I give you, because they have lots of good information on their website that they're willing to share to everybody. Now, to do a preventative, there are many classes of preventatives, and we have entire lectures on medication. In fact, Erica Marini will be talking about what's new in medications for migraine. But level A means that that's been proven by randomized controlled trials that these medications work. They have controlled with placebo medications and all that. Many of you may have been on some of these. They range in anticonvulsants like topiramate or divalproex sodium, beta blockers like metoprolol, propranolol, timolol, ACE inhibitors like candesartan, and then the new kid on the block for grade A evidence is the CGRP monoclonal antibodies. These three are monthly injections, arinamab, fremanezumab, and galcanezumab. Eptimizumab, which is a new one, is given intravenously and has to be done in the clinic. But these are all grade A evidence preventives that can be started when you have medication overuse headache. Grade B, these are very effective for many people. These are just as effective as level A. It's just that the data aren't as robust as the level A ones, but things like amitriptyline, venlafaxine, or this is Effexor, atenolol, nadolol, and then magnesium, feverfew, and riboflavin are herbals and vitamins that are also available. Then we also have onabotulinum toxin. Now, onabotulinum toxin has been approved for migraine, for chronic migraine. That's migraines occurring more than 15 days a month. And it takes about 2 weeks to get the full effect. And many people need more than one course. Usually we say at least 2 courses before we say that you failed that. There are very few side effects except for the pain with the injection site. And then you can have some ptosis sometimes. Rarely there's some kind of swallowing problems. But onabotulinum toxin is very effective for chronic migraine, and it's a great preventative. Now, which way should you come off the acute medication? So I've already told you that the way to do this is to start a preventive, and your provider can help you pick the preventive that's right for you. And then you have to come off. And remember, I gave you those choices of how to come off. Cold turkey, taper off, start the preventive, and then try to come off, or substitute the medication. There's no right way to do this. But we do have a study that maybe some of you even participated in called the Medication Overuse Treatment Strategy, or MOTS trial. And we're going to be publishing the results of this study. And the study looked at people who had chronic migraine medication overuse, and one group stopped at cold turkey and went on a preventative and got a different acute medication. The other group started a preventative and then just kind of came off of it as they could. And then we'll have an answer to that question: is one of these methods more superior to the other? We don't know, but this study is going to tell us the answer. So Sharon says to me, so if I start a preventive, what can I take for my migraine? Like, I still have to go to school and I still have to function. So let me tell you some options. The first option is to use a longer acting triptan. So there are many different triptans. Most of them are shorter acting, but there are 2 longer acting triptans, frovatriptan and naratriptan. And these 2 longer acting triptans sometimes work better for people who have medication overuse headache and keep getting their migraine headaches back over and over again. The second option is to try one of our new classes of acute treatments called G-PANTs. There are two of them, ubrogepant and ramigepant, and they block a completely different set of receptors. And we don't know yet if you can even get medication overuse headache from using these. Some people believe that you cannot get medication overuse headache. In fact, ramigepant is being studied to be taken every day as a preventative. So this class of drug may be very helpful for people who have medication overuse headache. Then there's another new class of drug called the ditans lasmiditan, uh, and that is a medication that is similar to a triptan, but it completely uses a different receptor. And because it's a triptan, we probably could get medication overuse headache from it, but it works differently, so it would be a good one to try. And then there's a list of medications that don't cause rebound or medication overuse headache, especially the phenothiazine. So things like promethazine, prochlorperazine, which are antiemetics, but they work also for headaches. Chlorpromazine is a very old drug, thorazine, and then other antiemetics like metoclopramide. Um, also can be taken, and you don't get medication overuse headache from these. I love the antihistamine hydroxyzine because it does help a little bit with the headache, but it also just keeps the anxiety level down so that you aren't fearful as much that you're going to get a headache. And then we've got a whole nother group called devices that we can use for acute treatment. And these devices are present so you don't even have to take medication. And all of these are now FDA cleared. So the first one is called the supraorbital nerve stimulator, sometimes known as the Cephally device. You can use it for acute treatment and preventive treatment. It has a dual action. So that's the supraorbital nerve stimulator. Then there's the vagal nerve stimulator, which is done transcutaneously on the neck, and it's FDA cleared for migraine, both for acute migraine and also for preventative. It does require a prescription, and it's some of these are not covered by insurance. Then there's transmagnetic stimulation. This is also FDA cleared for migraine, both acute migraine, but also for aura. When people have visual auras, you put it on the back of your head, you push the button, and it gives a little magnetic pulse and stops the aura and often prevents the headache. And then not finally, then there's the peripheral nerve stimulator, the Nerivio device. Now, this device is interesting in that you wear it on your arm and you activate it by your phone. And it's a very affordable device. I think you need a prescription to get this device as well. And then the newest kid on the block is a supraorbital and occipital nerve stimulator. So it stimulates the front of the head and also the back of the head. And it is right now being used for acute treatment of migraine. So these are non-medication ways to stop a headache. And if this would work for you, you are out of the medication realm altogether. Now, Sharon says to me, does this mean I can be done with medication overuse headache by just doing a preventative and changing it and all this kind of stuff? Well, that study's been done too, I said to Sharon. Uh, in a great big study, 17 studies with over 1,000 patients, about 3/4 of all the patients had success in the withdrawal therapy, meaning that they could reduce their headache days by over 50%. So they would go from chronic migraine, most of them, to episodic migraine. However, the relapse rate is high, 22 to 42%. And it's really, uh, really, the greatest risk is within the first 12 months after having medication overuse headache. The best prevention of medication overuse headache is to prevent it from the beginning, not to overuse, finding the right preventative, the right acute treatment that doesn't push you into medication overuse headache. Now, I would be really remiss if I didn't address all the things that need to be treated when somebody has chronic migraine. And you really do need to work on modifiable factors, predisposing modifiable factors that also put people into chronic migraine. Obesity is one. So weight loss really helps. Nutrition and diet are also very helpful. And we say there's certain foods that may or may not trigger migraine, but eating a healthy diet, drinking plenty of liquids, avoiding sugar is the best. And exercise. Exercise alone, just a little bit of exercise every day can help prevent chronic migraine. Another factor that is a predisposing factor is frequent headache. So if you have a lot of frequent headache, you really need to be on a preventative medication. And you want to think about behavioral modifications. And that brings that I'll talk about that in a minute. But think about getting the attack frequency down. Then stress reduction. We have been living in a very stressful time. Uh, how often do you live through a pandemic? We absolutely need better stress reduction techniques, mindfulness techniques, etc. Then sleep. If you're not sleeping at night, if you have insomnia, your migraine is going to be more chronic. And if you snore, it's a risk factor for chronic migraine. And we need to identify, diagnose, and treat sleep apnea and get good sleep hygiene. And then if there is concomitant depression, anxiety, we absolutely need to treat it because that can occur with chronic migraine. Depression and chronic migraine, there's a curve. And it doesn't mean that, you can't handle life or something like that. It's that this chronic migraine and depression are co-linked. They're like interlocking circles. And if you don't take care of the depression, you can't get rid of the chronic migraine. And if you don't take care of the chronic migraine, you can't get rid of the depression. They're co-linked. And anxiety is another factor because think about your day. If you're going to miss an activity, you're going to pop a pill and you're just going to try to just muscle on through it. But then you get anxious about, well, am I going to have a headache on that day? It's going to ruin my life. And then that anxiety itself can promote more headache. And then overuse of caffeine. Caffeine is a wonderful medicine. It's a medication. It has great properties for treating migraine, but it's a two-edged sword too, because it can actually cause more migraine. Cognitive behavioral therapy has been recently studied to show that it's as good as going on a preventative medication. And so I always recommend that to anybody with chronic migraine. It's a really good way but you have to find the right therapist that can help you with the stress reduction, mindfulness, treatment of anxiety, coming up with ways to um, sleep better and eat better, etc. And then know the limitations of your acute medicines. And if you're starting to get to that 10 days a month level, you've got to get some more help. Then you need to talk to your provider to get on a better preventive strategy for chronic migraine. I said at the beginning of this that I wanted everybody to sign up for the American Migraine Foundation because they have free newsletter, they have up-to-date information for patients, they have a Facebook group, and it's just AmericanMigraineFoundation.org. Join it. They have really good information. Here at the University of Utah, besides Headache School, we do have a headache booklet you can download for free. You can just even Google it. Headache booklet, University of Utah, and it's a PDF that you can download, and it has all the medications and devices listed in the booklet, and we try to keep that one up to date. So with that, this is St. Dymphna, the patron saint of migraine, individuals with migraine. Here she is holding a very experienced rabbit with some vapors, and this patient is going into mindfulness and thinking and coming up with a better way to treat their chronic migraine with medication overuse headache. And with that, I'm going to stop my sharing, and I'm also going to we'll stop the